So, dear postgraduates, this is one of the important topic in our clinical medicine. In fact, I feel that ILD should be treated by a physician rather than a pulmonologist, and you all agree with me at the end of my talk. Before going to the topic proper, I will tell you one of my close friends. In fact, very close to my heart. She is aged about 50 years, and her husband is AG MSc, a big fellow, and her family includes about 6 doctors, 2 DMs, 2 MDs, and 2 MBBS fellows. And she is a diabetic, and she presented with the cough and the dyspnea, and she visited one physician at Hyderabad, and he diagnosed earlier was a pneumonia, pneumonitis, or bronchitis, etc. He has given 2 or 3 sets of the antibiotics, but she was not happy, and symptoms are progressing. Then he approached another senior physician in the city of Hyderabad, and he had taken chest X-ray, etc., and diagnosed as the tuberculosis, and started ATT with your 4 intensive drugs, plus insulin for the proper management of the diabetes. After 2 months, at the end of the intensive phase, she developed hepatitis, mostly drug-induced hepatitis. It could be due to rifampicin. And then she was admitted in the hospital with bilirubin of 14. And later she developed the fever. Earlier there was no fever at all. She developed fever in the hospital, and then slowly went into a phase of sepsis, multi-organ failure, from there to the mortuary. Just before the 2 days or 3 days before her death, HRCT was done, and it showed ILD. It's a typical case of ILD misdiagnosed by the senior most physicians in the town and the city, and finally she lost her last breath at the age of just 51 years with a strong history of the diabetes and some cough, breathlessness. There were a lot of the stories like this. Earlier, interstitial lung disease was thought that in India, very rare disease. But now we are seeing a lot of the ILDs because of the 3 reasons. One is a more awareness of this problem. We are all aware of these ILDs as a postgraduates and also as a physicians. And number 2 is the game changer for the diagnosis of the ILD is the HRCT. And then we have the proper, after knowing the proper understanding of this ILD, now we have the beautiful drugs in our hand to start with the steroids. We have the immunosuppressive drugs like azathioprine, cyclophosphamide, methotrexate, and also we have the antifibrotic agents like nintedanib, etc. And finally, a stage will come where palliation or lung transplantation or heart and lung transplantation is the only answer for few of the very extensive ILDs. So with this background, I request you to spare some of your time to hear properly, to learn something about the ILD, which is a very important in our clinical practice. So what do you mean by the interstitium? It is all the structures that support the lung tissue. It includes the fibrous septae, alveolar walls, lymphatics, and pulmonary vessels. It is a tissue between your 2 alveoli. So what will happen when the patient is having the ILD? So the interstitial structures will become the thickened, inflamed, damaged. It occurs in an irregular fashion. Some structures will initially remain normal, while others will become very much inflamed. These are normally too small to be seen with the naked eye. An X-ray eventually becomes large enough to be visible. So not only the X-rays, now we have the HRCT is also very important to proper diagnosis of the ILDs. It's a group of the pulmonary disorders, maybe more than 200 diseases, with a common pathophysiological point is a radiologically diffused infiltrates, histologically by distortion of the gas exchanging units, so there will be the hypoxia and hypercapnia, and physiologically by destruction of the lung volumes and impaired oxygenation. So your vital capacity, total lung capacity, or DLCO, that is diffusion lung capacity of a carbon monoxide, all these will be reduced very much in the presence of the interstitial lung disease. In fact, the word interstitium is actually a misnomer if you see the spectrum of the disease of the ILD, because these ILDs are not always limited to your interstitium, but it also goes up to the alveolar epithelium, alveolar space, pulmonary microvasculature, respiratory bronchioles, larger airways, and also the pleura. So most of these ILDs left untreated, some of these cases could have a secondary pulmonary hypertension. Some people will have the hemoptysis, some people will have the pneumonitis, some people will have the pneumothorax. So these are all very often we see along with the ILD. So that in that way, this interstitium is a misnomer because it involves almost all the structures in the lung parenchyma. It is no more a rare disease. It is so common, and also it has a significant health burden. A diffuse pulmonary parenchymal diseases. These are the heterogeneous collection of the lung disorders characterized by the clinical, radiological, and pathological features. A series of the inflammatory and the fibrotic changes that involve the lung interstitium progress to the lung parenchyma. So at the end of the day, if you see the X-ray, the lungs will be very, very small. The oxygenated areas are also very, very small. Just like your CKD, if you see the ultrasound abdomen, CKD at the stage 5, small and contracted kidneys. The same thing happens in the ILD also at the end stage. So there will be the loss of the lung volume and the lungs appears to be very, very, very small. And if you see here two pictures, one is the normal, the second one is the abnormal alveoli. You can appreciate that in the abnormal alveoli, there will be thickening of the interstitium, there will be the distortion of these alveoli, and there will be narrowing of these alveoli. So the oxygenation will be impaired, and obviously they lead to the hypoxia and hypoxemia. The incidence is 30 for 1 lakh population per year, and these incidences are increasing year by year, maybe because of your pneumoconiosis, maybe because of air pollution, maybe because of your smoking habits. So the incidence of the ILD is increasing year by year. It is about 20% higher in the males than the females. So this is true as far as idiopathic IPF is concerned, whereas the primary interstitial lung disease are concerned. If you see the secondary ILDs, they are more common in the females because of the common occurrence with the connective tissue disorders. So ILDs, secondary to your connective tissue disorders like systemic sclerosis, rheumatoid arthritis, lupus, dermatomyositis, etc., they are very common in the females. So the primary or idiopathic ILDs are common in the males, whereas the secondary ILDs are more common in the females. The prevalence may be far more substantial than described as the diagnosis is challenging. ILD is a diagnosis of the exclusion that requires extensive investigation. So don't think that it is a diagnosis you should not think that it is a diagnosis of the exclusion, but you should include this ILD in your cases of all chronic cough and dyspnea. So all the cases of the chronic cough and the dyspnea, more than the 3 weeks or 3 months, so definitely you should see that it could be a case of the ILD and then act accordingly. In the pathogenesis, the first step is the fibroblast proliferation and the migration. Then you have the fibroblast to the myofibroblast differentiation. There will be the excessive extracellular matrix deposition. And finally, irreversible distortion of the lung architecture. See the alveoli, different shapes of the alveoli, and oxygenation will be limited in the presence of the extensive ILDs. In the same picture also you can see that irregular and abnormal air spaces in the second one, right? Large areas of the scarring, that is a fibrosis, and irregular thickening of the tissues between the alveoli. So these are the picture very often seen in the ILD, especially in the lower lobes mostly. Of course, upper lobes are also common if the patient is also having an associated sarcoidosis or the pneumoconiosis. Whereas most of the idiopathic pulmonary fibrosis are ILD secondary to the connective tissue disorders, mostly in the lower lobes, posterior aspects of the lobes. So idiopathic pulmonary fibrosis, one of the most commonly encountered ILD in the clinical practice. It's a progressive one, variable, unpredictable disease. Patients with IPF can lose approximately 150 to 200 ml of the lung function each year. So this is a dynamic disease and it is a progressive disease. So our aim is, after diagnosing the ILD, slow down the progression is our motto, not the curability of this disease. It's not a curable one, but definitely a preventable one. And also we can slow the progression of the disease by identifying the disease at an early stage and by intervening with your medical management. Goal of the treatment is to help the preserve the lung function. Whatever the lung function is there, it has to be preserved. A chronic fibrosing ILDs with a progressive phenotype behave clinically similar to the IPF, loss of the lung function, variable, etc. So there are the different examples like hypersensitivity pneumonitis, that is a very common in Indian population, and also the sarcoidosis. These two are very common in our population. Hypersensitivity pneumonitis, it is a reversible one, very good response with your steroids, 80 to 90% response with the steroids. Systemic sclerosis ILD is so common in the females. Crest syndrome, so C stands for calcinosis, R is for Raynaud's, E for esophageal dysmotility, S for yes, and then last T is telangiectasia. So that is your crest in the systemic sclerosis. Is a very common. About 60 to 80% of the systemic sclerosis people will be having the ILD. And other connective tissue disorders so common with ILDs are the rheumatoid arthritis, maybe 10 to 20%, and then the dermatomyositis, nearly 40 to 50%, and then sometimes Sjogren syndrome, maybe 5 to 10%. So these are the other connective tissue disorders along with the systemic sclerosis to have ILD. So the spectrum here is the idiopathic inflammatory pneumonias. The idiopathic pulmonary fibrosis is the sheet one, and then the idiopathic non-specific interstitial pneumonias and other different pneumonias are there. But as a postgraduate, you should all aware of these things: respiratory bronchiolitis, interstitial lung disease, dyspneumatic interstitial pneumonia, cryptogenic organizing pneumonia, also called as COP, acute interstitial pneumonia, AIP. So interstitial pneumonia, not always chronic, mostly 90% is a chronic. Sometimes 5 to 10% of these cases may be acute presentation also. That is acute interstitial pneumonias. So already told you the secondary to autoimmune, all these diseases like systemic sclerosis, etc. That is one spectrum. Hypersensitive pneumonitis is a very common in our Indian population. By hypersensitive exposure to some gases or some the perfumes, etc. And sarcoidosis is so common with your hilar adenopathy and mediastinal adenopathy, and you will have the lymphocyte predominance here in sarcoidosis. So others also there. So if you see that the idiopathic pulmonary fibrosis and acute interstitial pneumonias are secondary to the autoimmune diseases, hypersensitive pneumonitis, sarcoidosis, these are the different subsets, very common subsets of your ILD spectrum. So the same thing here, the primary and the secondary, as I told you, the primary exact cause is not known. Secondary to some cause. And if you identify the secondary cause, definitely the treatment will be very easy, because by treating the secondary cause, so definitely the progression of the ILD will be halted. So these are the primary or the idiopathic, where exact cause is not known. That is UIP, that is the usual interstitial pneumonia, also called as IPF, idiopathic pulmonary fibrosis. Non-specific interstitial pneumonia, that is the NSIP. Cryptogenic organizing pneumonia, that is the COP. Respiratory bronchiolitic associated ILD, RBILD. Acute interstitial pneumonia, AIP. Dyspneumatic interstitial pneumonia, DIP. And lymphocytic interstitial pneumonia, LIP. Sometimes in your exams, as a short notes, so they may ask COP, COP, or DIP, or LIP like that. So these are the important secondary causes. So some infections or non-infections. Infections, most important is coronavirus. So the post-corona, lot of the people are having the pulmonary fibrosis. So there is a main one among the viruses. And other diseases like tuberculosis. So definitely there are a lot of the fibrosis, sequelae of the tuberculosis. Bacterial infections, fungal infections, parasitic infections. So these are the infections which causes the pulmonary fibrosis. Non-infectious causes, hypersensitive pneumonitis, pneumoconiosis, drug-induced. Certain drugs are there. I will tell you at a later time what are all the drugs that may cause the pulmonary fibrosis. radiation induced, that is also very, very common in our setup. So nowadays, no, each city is having 2 or 3 cancer hospitals. So all the cancer hospitals are filled with the radiation oncologists, surgical oncologists, medical oncologists, etc. So because of this radiation induced pulmonary fibrosis is also very, very common nowadays. Malignancies, so you know that the malignancies are increasing in number nowadays. Systemic vasculitis. So these are all the secondary causes. Association with the disease of the unknown etiology. Sarcoid is the sheet anchor. Already you know better than me about the features of the sarcoidosis. And almost all the connective tissue disorders will lead to the ILD and also eosinophilic pneumonia. So chronic eosinophilic pneumonia. So that also resembles like the ILD, but the treatment will be easy if you diagnose the eosinophilic pneumonias. The clinical manifestations, the dyspnea and exertion, a most frequent symptom, directly correlated with the quality of the life and the survival. So definitely the quality of the life depends on your dyspnea stage. If it is the dyspnea at stage 4, so dyspnea trust, so definitely the quality of the life will be very much deranged. Dry hacking cough, that is very, very important, not the productive cough. The cough here is the dry cough. Dry hacking cough is a very common symptom in the ILDs, more prevalent in the non-smokers and in the severe disease, independent predictor of the disease progression. Then the inspiratory crackles. So because of the sudden opening of your alveoli, blocked alveoli, so there will be the velcro crackles at the end of the deep inspiration, not in the expiration. Expiration will be the normal, but at the end of the inspiration, you will have the fine crackles at the bases of the lungs. So it should be think of the ILD. Clubbing of the disease, yes, in about 30 to 50% of the patients because of the chronic hypoxia. Correlated to the extent of the smooth muscle proliferation with areas of the fibrotic changes in the lungs. Unintentional weight loss, yes, like your type 1 diabetes or hyperthyroidism, here also there will be the unintentional weight loss. And underlying CTDs, very common in the females. So when they have the peripheral polyarthritis, think of rheumatoid arthritis. Okay, so if any pinching of the skin is very tight, so definitely think of the systemic sclerosis. And then the hair loss or butterfly rash or oral ulcers, so think of the lupus. So these are some of the common diseases we can think and we can identify them as an history itself or by the clinical examination. So these are how ILDs will be associated with your connective tissue disorders. So these are the common manifestations. The same thing here, but what is important is the prognosis of the ILD varies highly with the time. So it is our duty of an astute physician. You should identify the ILD at an early time, and also you should know the type of the ILDs also, because the prognosis depends on your subdiagnosis of your ILDs. So the 5-year mortality ranges from 20% in idiopathic pulmonary fibrosis to 100% in the cryptogenic organizing pneumonia. So in cough, you have the 100% mortality. Whereas if you diagnose idiopathic pulmonary fibrosis, you are safe that maybe the 20% mortality. Okay, so this is the very, very important. Otherwise, the same thing here, the cough, breathlessness, clubbing, etc. It's a progressive dyspnea, a chronic dyspnea, a dynamic with an exertion or the persistent dry cough or the usual complaints. So a progressive dyspnea with a dry cough in young females, underground of connective tissue disorders. So please think of the interstitial lung disease. Respiratory symptoms are with another disease such as the connective tissue disease. No respiratory symptoms but abnormal chest X-ray. See, the normal chest X-ray does not rule out the ILDs. Okay, so sometimes no, our diagnosis is ILD. If you take an X-ray, X-ray is absolutely normal. So that could be there in about 10% of the cases. Just like your ECG in acute myocardial infarction. So your lot of the chest pain, diaphoresis, breathlessness, uncontrolled diabetes, uncontrolled hypertension, strong family history of ischemic heart disease, he presented to you. So basically the diagnosis is acute myocardial infarction. Okay, if you take an ECG, that is a normal. So the right normal ECG in the beginning, you should not rule out the ischemic heart disease. So observe the patient. After 1 hour, you will find a beautiful changes in your ECG. Okay, meanwhile, you will get the troponin, etc. So to establish your diagnosis of the ischemic heart disease and then act accordingly. In the same way, if your diagnosis is ILD clinically, if the chest X-ray is normal, it is not 100% excluded. So it could be possible normal X-ray in 10%. The vice versa is also possible. He is asymptomatic, absolutely. But X-ray shows very extensive ILD. That is also possible in some cases. Okay. So abnormal PFT, especially restrictive ventilator pattern. So pulmonary function test. Usually use two things in pulmonary function test: restrictive pattern and obstructive pattern. So obstructive pattern you see in bronchial asthma types, whereas here it is a restrictive pattern. Okay, your FVC will be reduced, total lung capacity will be reduced, and also your DLCO also will be drastically reduced in the presence of interstitial lung diseases. So age will help you to some extent. Suppose if the age is 20 to 40 years, the probable diagnosis of the sarcoidosis or connective tissue disorders or LAM or EZ, etc. If it is more than the 50 years, so our diagnosis of the ALD, 20% mortality rate, easily treatable with good lifespan, is your idiopathic pulmonary fibrosis. Okay. Gender also matters a lot. As I told the male, so the mostly the smokers, etc. In the females, even at the younger age with connective tissue disorders, they will be having it. So premenopausal female, it is a LAM, that is lymphangiomatosis. In females, predominant ILD is also the connective tissue disorders. Males, mostly the pneumoconiosis and sometimes rheumatoid arthritis. Diseases associated with the smokers. So histiocytosis, dyspneumatic interstitial pneumonias, respiratory bronchiolitis. So diseases less likely to be seen in the smokers are hypersensitivity pneumonitis and sarcoidosis. Pulmonary hemorrhage is a far more frequent in the current smokers with Goodpasture syndrome. So it presents with ILD with hemoptysis or with pulmonary hemorrhage. So think of the Goodpasture syndrome along with your connective disorders. Duration, yes, an acute, that is less than the 3 weeks. Drug reactions or acute hypersensitivity pneumonitis or chemical exposures, and very easy to treat also. You will have a tremendous response with your steroids in these cases, and withdrawal of the drug also will help you a lot. So that is your acute interstitial pneumonia where 100% recovery is guaranteed. Whereas subacute in about the 3 to 12 weeks and chronic more than the 12 weeks. Intensity of the symptoms. Minimal symptoms in the presence of grossly abnormal chest X-ray, example sarcoidosis and histiocytosis. The patient is mildly symptomatic or mostly the asymptomatic also, but X-ray shows an extensive diseases. So please think of the sarcoidosis or histiocytosis. And again in the sarcoidosis you can easily pick up some of the other findings also like hilar adenopathy or mediastinal adenopathy, etc. And if you advise the ball, bronchoalveolar lavage, you will have the predominant lymphocytes in sarcoidosis. Whereas in idiopathic pulmonary fibrosis, you will have the polymorphs. So polymorphs dominance in idiopathic pulmonary fibrosis, whereas the lymphocytosis predominates in your sarcoidosis. Severe symptoms in the presence of the mild radiograph abnormalities is also there. Okay, the patient is very symptomatic, but the X-rays very, very mild changes. So there is idiopathic pulmonary fibrosis and hypersensitive pneumonitis. So both can be treatable reasonably. A sudden worsening of the dyspnea, particularly if associated with the pleural pain. So pleuritic pain, chest pain, and also the sudden onset of the breathlessness, like your pulmonary embolism. But here, don't think the pulmonary embolism, but think of the pneumothorax in ILD. Okay. So the family history, it runs in the families. Occasionally it is helpful. And autosomal dominant, IVF, sarcoidosis, neurofibromatosis, etc. So these are the drugs which causes the interstitial lung diseases. Very, very common drugs we use every day. For example, nitrofurantoin. So it's a very useful drug used in the urinary tract infections. Maybe 3 days, 5 days, sometimes 1 month, 2 months, 3 months, 6 months in a chronic UTIs, etc. Sulfasalazine, very useful drug DMRD in ankylosing spondylitis. So in axial skeletal spondyloarthritis, we often use the sulfasalazine, starts with the 500 milligrams OD and then the 500 milligrams BD next week, and then 500 milligrams TAD third week, and maybe 1000 milligrams BD also fourth week onwards. So that's how we have to uptitrate the doses of the sulfasalazine once your diagnosis the ankylosing spondylitis with your bamboo spines, etc. And of course, you have to use the biologicals also along with these sulfasalazine like rituximab or infliximab or your adalimumab, etc. Aspirin is a very, very favorite drug for most of our physicians and the cardiologists and the neurologists. So aspirin also will cause the interstitial lung diseases. Gold and penicillin we are not using. They are the DMRDs earlier, but now we have the introduction of your methotrexate, etc. So these gold and penicillin no more useful. Antibiotics, bleomycin, mitomycin, cyclophosphamide and chlorambucil are very much useful in our daily practice. So when the fellow is in the crisis, so sickle cell crisis, sorry, not the sickle cell crisis, in your systemic sclerosis crisis, etc. In connective tissue disorders, we use the cyclophosphamide as a pulse therapy. 500 milligrams or the 1 gram cyclophosphamide mixed in 100 ml of the normal saline, run over about 2 to 3 hours once in a month for about 6 months or maybe 1 year. Sometimes you can also use the tablets of cyclophosphamide 500 milligrams once a day for most of the population. In the same way, use the other antibiotics. Methotrexate is your favorite drug, number one drug to be used in rheumatoid arthritis. You can start with 5 milligrams, 7.5 milligrams, 10 milligrams, 15 milligrams, 20 milligrams, 25 milligrams, but once in a week. And you have to supplement with the folic acid supplementation because methotrexate is folic acid antagonist. So see the oxygen, a double-edged weapon. So it's very much useful in the chronic ILDs population, but oxygen also can cause lung injury. And oxygen also can potentiate your inflammatory fibrosis. So you should know how to use the oxygen, how much you have to use, how long you have to use, all these things. Oxygen therapy, don't think that it's a small one. It's a very, very big one in the presence of your post days of your COVID. So we have given a lot of the respect to the oxygen in those days. Without the oxygen, a lot of the people they succumb to the death because of the poor oxygen supply in those days. Already I told something about the radiation. Other drugs, INH, we often use in COX. Hydralazine is a good vasodilator. It's a very useful drug in resistant hypertension and also in the renal hypertension. Also during pregnancy, pregnancy-induced hypertension, or in eclampsias, or in hypertensive urgencies and emergencies, we use hydralazine. Hair oil. So that is a big illicit drugs. So they also you should remember. So these are the important drugs that may cause interstitial lung disease. So what I mean to say is, whenever a fellow with a constitutive disorder, especially the female, when they have the chronic history of the dry cough, a progressive dyspnea, so try to avoid these drugs because already the patient is in the ILD, and if you use these drugs, and definitely there will be the progression of the disease. So we have to arrest the disease by avoiding these drugs as long as possible. So we often use aspirin as antithrombotic agents, antiplatelet agent. So you can use the clopidogrel in the place of the aspirin there. So we use the nitrofuran for the UTIs. So you can use the azithromycin here in the place of your nitrofurantoin. So in that way, we can exchange some of the drugs which will not cause the ILD. But if you use these drugs, they are the potential candidates to get the drug-induced ILDs. Occupational history is very, very important, mostly the males, because a lot of the people, they work in the mines, etc. So the pneumoconiosis is very, very important in this occupational history. So these are the different items exposed to these things. In the agricultural people, so the nitrogen dioxide. In the electrical arc welding, there is the nitrogen oxide. Okay, so the sulfur dioxide, sulfides, fumigants, oxygen in the mechanical ventilation. So these are all the different things for the pneumoconiosis. The coal mining, graphite, silica, asbestos. So they lead to a lot of the diseases here. Talc, mica, iron ores, workers, silver and iron tin. So jewelry making, mining, etc. They are more prone for the pneumoconiosis. So already told you the dyspnea and some words about the cough. It's a dry cough, and not productive one. It's a common and seen in conditions that involve the airways, especially the sarcoidosis in boob, bronchiolitis obliterans, respiratory bronchiolitis, pulmonary histiocytosis, hypersensitivity pneumonitis, etc. And the final take-home point here is the productive cough is unusual in interstitial lung diseases. Okay. So when the fellow is having the cough and the breathlessness, you ask the leading question of is the cough is productive or not. So what is the color of the sputum? What is the amount of the sputum, etc. So he immediately says that my cough is always a dry cough, not a productive one. So that point clinches towards your ILD. Once the cough is productive, you can exclude the ILD in most of the cases. Wheezing again is an uncommon symptoms. In lymphangitic carcinomatosis, chronic eosinophilic pneumonias, etc. Chest pain is an uncommon symptom. Hemoptysis invokes the differential diagnosis of the diffuse alveolar hemorrhage syndromes, pulmonary veno-occlusive diseases, MS, LAM. Here MS means mitral stenosis, not with the metabolic syndrome, granulomatosis vasculititis. New onset of the hemoptysis in a patient with a known ILD suggests a complicating malignancy. That is again a beautiful carry-home point. In your known case of the ILD, now presenting with the hemoptysis. So think that maybe complicating malignancy. I will show you a picture here. So how this malignancy appears in your chest X-ray in a known case of the ILD. So the new onset of the hemoptysis in a known ILD patient, always think of the complicating malignancy. Fever, almost never associate the fever in most of these conditions, connective disorders, etc. So extra thoracic manifestations. As a acute physician, that is the reason I told you earlier that ILD it's the physician's disease to diagnose and to treat and to monitor and for the follow-up because of these things. See the extra thoracic manifestations. So the nasal discharge, upper airway symptom that suggests the Wegener's granulomatosis. Arthritis, see the females, most of the people will have the arthritis, I told you. So these are all should be treated is an extra thoracic. So should be treated or diagnosed by the physicians like you. And then arthritis, but never the true sign of it is the idiopathic pulmonary fibrosis and skin rashes. So skin will give you a lot of the information in general medicine. So in fact, no, you should have one class exclusively on the skin and physician. With a good dermatologist, you should ask one of the good dermatologist to take a class on skin and general medicine. A lot of the diseases can be seen by examining the skin. So inspectory diagnoses. So here the sarcoidosis, CVD and granulomatosis vasculitis. So these are all the skin rashes. Yes, again your internal medicine. Neurological manifestations in ILD. So a lot of the symptoms, CNS symptoms, it's like your headache or maybe the convulsions or asthenia or mood changes or irritability or sleeplessnesses. So these are all very common in your ILD population. See lymphomatoid granulomatosis or mononeuritis multiplex. Proximal muscle weakness is one of the diagnostic criteria for polymyositis and dermatomyositis. Again, the polymyositis and dermatomyositis also again associated connective disorders with the ILDs. So the proximal muscle weakness. So think of PM or the DM and then the biopsy will clinch the diagnosis. Okay. So dysphagia, again here the polymyositis, the dermatomyositis and progressive systemic sclerosis. Physical diagnosis, little diagnostic specificity, diffuse crackles, the presence or the absence adds the little, may be present in the presence of the normal chest X-ray also. Velcro rails are common in most forms of the ILDs. They are less likely to be heard in sarcoidosis. Inspiratory specs, typical of the boof. Clubbing, idiopathic pulmonary fibrosis but non-specific. Carpulmonale is common here. because of the associated your pulmonary tuberculosis, pulmonary hypertension. Cyanosis in the late stages of the ILD because of the chronic and exaggerated hypoxia, and extrathoracic findings direct to but not the diagnostic. So as a physician, if your diagnosis is ILD, you should see 360 degrees. So whatever the skin, whatever the joints, okay, whatever the heart, whatever the pulmonary hypertension, and about the neurological things. So these are also very important in the proper diagnosis and the management of the ILDs. Coming to the laboratory evaluation, you will have the peripheral eosinophilia more than the 10%. Here these two conditions, and abnormal renal function. See the pulmonary renal syndromes. So far you had the cardiorenal syndromes. So the type of stage 1, stage 2, stage 3, etc. So acute cardiorenal, chronic cardiorenal, or acute renocardiac, or chronic renocardiac, and then systemic diseases complicating the cardiorenal syndrome. That is how you differentiate the 5 types of the cardiorenal syndromes. In the same way here, they are the pulmonary renal syndromes. So you have to respect the kidneys in all the ILD population. So avoid the nephrotoxic drugs, especially the contrast materials or your aminoglycosides, okay, etc. And then the ANCA and the anti-GBM, that is, these are all very common with your vasculitis cases. So these are the different laboratory findings you often see in leukopenia, eosinophilia, thrombocytopenia, hemolytic anemia, normocytic anemia, urinary sediment abnormalities, hypogammaglobulinemia, hypergammaglobulinemia, serum immune complexes, so serum angiotensin converting enzyme. So that is a very common in your sarcoidosis. So there will be the elevated ACE in the presence of the sarcoidosis. Okay. So anti-basement membrane antibodies, anti-neutrophil cytoplasmic antibodies. See the chain of the investigations. Who will order all this except the other than the physician? So that is the reason don't refer the ILDs to the pulmonologist. Okay. So it's you person are the better persons to diagnose or to treat the ILDs. So they need we have to send them for only your bronchoscopies or your lung biopsies. So they are needed only 5 to 10% of the cases. So 90 to 95% of the ILDs, they don't require any bronchoscopy or bronchoalveolar lavage or thoracoscopy, etc. See the pulmonary function test. Most of the ILDs have a restrictive defect. Already I told you this point. Smoking history should be considered, and there may be the mixed pattern in certain diseases like your sarcoidosis or hypersensitivity pneumonitis, histiocytosis, etc. Moderate to severe reduction in DLCO, that is the diffusing lung capacity of your carbon monoxide, but normal lung volumes in a patient with ILD suggests COPD with ILD. In COPD with ILD, there will be the normal lung volumes, but there will be reduction in your DLCO. Whereas in inflammatory pulmonary fibrosis, there will be reduction both. So DLCO will be reduced as well as the normal lung volumes also will be reduced. Chest X-ray is often suspected on the basis of an abnormal chest X-ray. Most of the times, if the physician is not a good physician, definitely he will not pick up the ILD on history or the clinical examination. Only your chest X-rays or HRCTs will tell you retrospectively. So it should be always proactive, not the reactive. So this is very important. So review all the previous films to assess the rate of the change in the disease. That is very important. So once you see some abnormality in your chest X-ray and you are thinking in the times of the ILDs, please get the old X-rays also, and then see the serial X-rays to see the changes in the parenchyma. See, I told you already this point, chest X-ray could be the normal in 10% of the ILDs. So by reading the chest X-ray, you please concentrate on the interstitial pattern, that is between the ribs. Between the ribs. So you will have a reticular pattern, a linear pattern, or a nodular pattern, or reticulonodular pattern. These things can be seen between the ribs, mostly in the lower lobes. And of course, in pneumoconiosis or in sarcoidosis, the upper lobes may be involved, but most of the cases, maybe 70 to 90% of the cases, it is the lower lobe involvement between the ribs. You can see all these things. And definitely the lung volume also will be reduced very much. So there will be the ground glass appearance, should be limited to the HRCT technique, that is mostly appreciated in the HRCTs. So the distribution of the disease, pleural involvement, hilar and mediastinal adenopathy, and pneumothorax help to narrow the differential diagnosis. So don't be happy by seeing only the interstitial areas. So see whether the hilar is the normal or the not, whether any mediastinal lymphadenopathy is there or not, if any pleural effusion or pneumothorax, or any long fibrosis and deviation or pulling of your trachea to the one side. And these are also very important points to be seen in your chest X-rays. Not only that, your heart margins. So the heart margins are also not clearly made out in the ILD. So as I told you that the nodular pattern, so the nodules, a multiple nodule, usually here the nodule size will be less than the 2 millimeters. And more than the 5 millimeters or more than the 10 millimeters, it is not typical of your interstitial lung diseases. If the multiple nodules are there in the sarcoidosis, in vasculitis, vaginous granulomatosis, etc., and hilar and mediastinal lymphadenopathy in sarcoidosis. And pleural plaques, asbestosis, a pleural effusion, that is a rheumatoid lung disease, or lupus, very rare in sarcoidosis, or spontaneous pneumothorax, a lobar or segmental infiltrates. Why I am showing all these things is, so by seeing the ILD, once your diagnosis is the ILD, suppose if the patient is also having the pleural plaques, then your diagnosis is mostly the asbestosis. Suppose on X-ray if the patient is having the spontaneous pneumothorax, then your diagnosis is maybe 1 or 2 points. If the patient is having the pleural effusion, it could be the secondary to your connective tissue disorders like rheumatoid arthritis or lupus. So these things will help. When the patient is having the multiple nodules, so these are the different DDs. So the approach to a patient with a suspected ILD is first history. So history is very, very important. So as a good physician, as an astute physician, you should spend some time with the patient. Even today, after so many investigations in our hand, I think history, and history. This is a very, very important for about 80 to 85% of the cases. If you don't come to a reasonable diagnosis of history alone, you are not a good physician. Other investigations will tell you the differential diagnosis to include or to exclude. But you should come to a reasonable diagnosis, maybe 1 or 2, 3 points, 3 diagnoses in your history part only. Then only you can reduce the, exclude the other causes, and then finally come to a reasonable diagnosis. But unfortunately, today's generation, so they are not spending much time with the history. They are always investigation oriented. So don't treat the investigation. Treat the patient with the disease, not the disease. This is the very, very important. So the family history is very important. With history, you can come to a reasonable diagnosis. Examination is also very important. Suppose if you are thinking of the ILD, so you have to consider the inspiration, not the expiration. Okay? At the end of the inspiration, you will have a crackles. So this is the very important in the ILD population. Chest X-ray, very, very important in the ILDs. Maybe 10% may be abnormal. But if it's an abnormal, we can find out the sum of the causes there. Maybe the pleural effusion or the pneumothorax or any nodules or multiple nodules or any hilar adenopathies or upper lobe involvement or lower lobe involvement or distortion of your cardiac borders or any cardiomegaly or pulmonary carpulmonale or pulmonary hypertension. See, all these things will be seen, or curly V lines. So all these things will be seen in your X-ray. So that must of the understanding or the education you should have while reading the chest X-ray. And of course, lung function test again, whether it is a restrictive or an obstructive. In the restrictive, what matters are the restricted? How much it is restricted? Is it 5% restriction or less than the 10% or more than the 15%? So again, the diagnosis depends on these restrictive patterns. And HRCT is a very, very important. I told you earlier that's a game changer. Now every place we are having the CT scans and HRCTs. So beautifully you can see the destruction of this architecture and honeycombing, and then the fibrosis and the loss of the lung volume. These all will be appreciated in your HRCTs. And of course, the biopsy, they are needed only in the 5 to 10% of the cases. There we can take the help of our friends, good friends, of the pulmonary pulmonologist or interventional pulmonologist. We can take the help of those fellows. But up to 90% of these ILDs, you are supposed to see, you are supposed to diagnose, you are supposed to rule out all other causes and then treat accordingly. So what are the causes of the abnormal interstitial shadowing on chest X-ray? There are many causes. Yes, two important ones are idiopathic, leading to the idiopathic pulmonary fibrosis or cardiogenic interstitial pulmonary edema. See the pulmonary edema presentation. Sometimes no. So need not be always lung wise. So sometimes there may be a card pulmonary, as I told you, or maybe the pulmonary hypertension, or maybe the acute heart failure, or acute left ventricular failure, or acute right ventricular failure. So that is also a possibility here. So there are the drugs as such as farmer's lung, bird lover's lung, in the same way mushroom picker's lung. So there are the different names given to those professionals. So if you don't take the history of the bird lovers living all that day and the night with the birds, you are going to miss this pneumoconiosis and ILDs. In the same way, mushroom pickers lung or air conditioners lung. So all these years, no, they work in the air conditioner, especially in the months of the March, April, May, June. All the workers, for AC workers, they are so busy. So must be having some element of your pneumoconiosis or ILD because of these exposure to the arc welding, etc. So this is the very, very important lung positions. One should ask for that. See here, that's what I told you. So between the ribs, you concentrate. There may be the fine lines, regular shadowing, small nodules, maybe the larger nodules. So think of something else other than your ILD, maybe early malignancies, lung volume loss by seeing the X-ray. No, so the oxygenation is very, very low. So lung volume is very, very loss. Honeycombing, yes, and fibrosis. A good place to look for ILD is between the rib spaces. Between the rib spaces, close to the chest wall, mostly the peripheral, not towards your heart, towards the peripheral, towards the chest wall, between the ribs. There should normally be very few lung markings, very, very few lung marks there, but certainly no nodules or the fine lines. So that is the normal physiology, normal X-ray. The normal X-ray, if you see at the chest wall side, between the ribs, so no nodules there, only fine lines, very few lung markings. But you see the different structures like fine lines, small nodules, large nodules, volume loss, reticular pattern or reticular nodular pattern. So always think of the ILD in the context of your history. See here. So what is the abnormality here? So we have to concentrate on the clavicle, you have to see the scapula, you have to see the secondaries there, or pathological fractures. Okay, in the same way the rib fractures or notching of the ribs. Okay, in coarctation of the aorta, you have the rib notching. Okay, maybe the tubes, you can see the picture in chest X-ray. Okay, pleural effusion or pneumothorax, tube insertions, etc. can be seen clearly. So skin and soft tissues. Okay, or surgical emphysema. You can appreciate here in the chest X-ray. In the way massive hepatomegaly. So elevated right dome of the diaphragm. Okay, or perforation, your halo viscous perforation. So you can see the gas under the diaphragm. It's a surgical emergency. You have to subject for the laparotomy. Then the gas shadows on the left side, left diaphragm, lowered. Okay, finally, we have to see the trachea, we have to see the clavicle, we have to see the scapula, we have to see the subcutaneous areas to rule out the subcutaneous emphysemas or tubes, and then the diaphragms or the below diaphragm, infradiaphragmatic on the right side and the left side. Okay, and then the costophrenic angles, cardiophrenic angles, right border of the heart, left border of the heart, and then the hilum, there is hilar adenopathy, etc., and the pulmonary vessels, vasculature, so pulmonary arterial hypertension, etc. So this is how we have to read, of course, right upper lobe, right mid lobe, right lower lobe, and left upper lobe and left lower lobe. So that's how we have to, all these points you should see in X-ray. That's very, very important. See here the pattern. See the reticular nodular shadowing. You can see, appreciate here the between the ribs. Okay. See here irregular heart border. Heart border is not clearly made out here. And then the most important thing, and you're all missing, is this point, this nodule. This patient has a lung cancer, a complication of the pulmonary fibrosis. This nodule is a very big nodule, not the nodule of your size of interstitial lung disease. Okay, so see here, most of the times, no, okay, absolutely okay, fine, X-ray is okay, give us some antibiotic, azithromycin, doxycycline, amoxiclav, సరిపోదు, because you are totally wrong. You are thinking in lines of some bronchitis or some pneumonitis, but the picture here is you concentrate on the reticulonodular pattern here between the ribs. See the hot borders, not clearly made out, and see the big nodule here. Okay, so big nodule here. So this is the malignancy. So this is how. So this is a case of ILD going into malignancy. Malignancy. See the difference. Okay. So you are making the patient to die much early, or you are giving good quality of the life. Depends on your reading of your X-rays. You are in a doubt, send for HRCT here. Always take the advantage of HRCT. So this patient has to be advised HRCT for the further findings in the both the lungs and the to know that nodule of any possibility, some biopsy. These are very, very important. So the take-home points here, with the interstitial lung disease has a characteristic appearance on the chest X-ray. Look between the rib spaces for the presence of the extra nodules and the fine rails. High resolution CT is a useful test to evaluate the suspected cases of the ILD. How ILD be investigated? So I told you the HRCT. Some causes have the specific appearances. PFTs, so that is very much useful. Lung biopsy and blood test. Suppose you have the secondary ILDs. So if you diagnose the systemic sclerosis, so get these tests done. SSC 70. And if your diagnosis is rheumatoid arthritis, get the CRP, RA, and anti-CC. Or your lupus, so definitely ANE or double standard DNA, UN, RNP, etc. Okay. Or your dermatomyositis, myositis, you have the specific markers there, or anti-Ro, anti-La in Sjogren's syndrome. So these are very important investigations. You can get it done with the blood test to identify or to substantiate your diagnosis that it is a secondary ILD. So choice of the test depends on your clinical presentation. See here the spirometry. A restrictive defects, a reduced titer value, FVC and total lung capacity, increased FV1 by FVC and the decreased DLCO with increasing severity of the disease, and 6-minute walk test. This is also, there will be the big desaturation. So these are the pulmonary tests and the walk test. See the CT, how distorted it is with the loss of the lung volume, honeycombing, architectural loss, etc. So role of the lung biopsy, as I told you that it's not required to make the diagnosis in all patients with ILD. So without the lung biopsy also you can diagnose the ILDs. So only few cases. Indications for the lung biopsy, this is very, very important. To assess the disease activity, to exclude the neoplasm of the infection, to identify a more treatable condition, to establish a definitive diagnosis before starting a treatment with a serious side effects, to provide a specific diagnosis in patients with atypically or progressive pattern, or a normal or atypical chest X-ray features. So these are all the indications for the lung biopsy. Bronchoscopy is often the initial procedure of the choice. Endobronchial lesions like sarcoidosis and vaginous granulomatosis. Transbronchial biopsy may be a diagnostic of the sarcoidosis. The treatment will be very excellent. Wall, the bronchoalveolar lavage. So here no CD4 and a CD8 count ratio. So the macrophage predominant in sarcoidosis. Sorry, lymphocytosis predominant in sarcoidosis, where a macrophage predominant in the interstitial fibrosis. Surgical biopsy. Some contraindications: serious cardiovascular disease, radiographic evidence of the diffuse end-stage disease, honeycombing, and severe pulmonary dysfunction. So what are the objectives of the treatment of the interstitial lung diseases? provide the symptom relief. So that can be done by all of you. Slow down the disease progression. With a good understanding of the ILD, we can definitely slow down the progression. Prevent the complications. So that is very important. So if you slow down the disease progression, obviously you won't find any complications. Improve the quality of the life, prolong the survival, and prevent the treatment complications. So your treatment also will cause some of the complications, especially oxygen injury. Oxygen therapy also will aggravate your fibrosis. So end of the care, finally, the palliation measures. So this is the pharmacological management. You have the antifibrotic drugs like nintedanib or pirfenidone, anti-inflammatories like steroids, treatment of the cough with opiates, dextromethorphan and guaifenesin, and treatment of the comorbidities like RA or SLE, etc. etc. A word about the corticosteroids. Here the corticosteroids has to be used in a very high dosages. Maybe 1.5 to 2 milligrams per kg body weight. For example, if a person is about 70 kgs, so we have to use nearly 100 mg to 150 mg. How long? Not 5 days or 1 week. Maybe 1 to 2 months. So high doses of the steroids for about the 1 to 2 months, and then maintenance dose of not 5 mg or 10 mg, 15 mg to 20 mg as the maintenance dose for about 6 months to the 1 year. So that is the treatment of your interstitial pulmonary fibrosis. Here we have to use the high dosages like 1 to 1.5 milligrams per kg body weight for about 1.5 to 2 months, and then about the 15 milligrams to 20 milligrams of the corticosteroids for about 6 months to the 1 year, beyond 1 year also. So very high doses of the steroids has to be given. So as a physician, we all know the side effects of the steroid therapy. So your Cushingoid phases, or your steroid-induced diabetes, or hypertension, osteoporosis. So these are very important, and then the gastritis. Okay, so they are important side effects of or complications of your steroid therapy. And then the nintedanib and the pirfenidone, I will tell you at a later time. And see here, non-pharmacological management. So this is a very, very important, because in this disease, where the few drugs are available to treat it, but non-pharmacological management also plays a major role here. Smoking cessation, lifestyle modifications, healthy weight. So if they are overweight or the obese, reduce it. Supplemental oxygen. So how much oxygen, how long? So this is also very important. You have to tell to the attendants. And pulmonary rehabilitation. So this is also very important. And finally, vaccinations. Your H influenza vaccination once in a year, and pneumococcal vaccination maybe once in 3 years or the 5 years, depending on the type of the vaccine, pneumococcal vaccine you advise. So these two are very, very important in ILD population. And the end of the life care, a dignified life, and then finally palliation. So if the patient needs a surgical management, so the only answer is a lung transplant or lung and heart transplant. So lung transplant if the heart is the normal, or lung and heart transplant when the fellow is also having the carpulmonary or ischemic heart disease or associated ischemic heart disease, etc. So these are the different drugs used in the treatment. Anti-inflammatory drugs, corticosteroids. Already told you the doses of the corticosteroids and side effects of the corticosteroids you know very well. And methotrexate, yes. Azathioprine, cyclophosphamide. So these are the very important. See, azathioprine, a beautiful drug to be used in the ILD population in the strengths of 25 milligrams and the 50 milligrams. Cyclophosphamide, already told you the pulse therapy. So 500 milligrams to 1 gram cyclophosphamide once in a month for about 6 months to the 1 year, or every day also you can use in the doses of 250 to 500 milligrams. Antifibrotic cases, nintedanib. So I will tell you at a later time, maybe 150 milligrams BD. We have to use this drug, and this is very popular post-COVID. Supportive and supplemental oxygen like oxygens, pulmonary vasodilators, diuretics, antibiotics if the second infection is there, rehabilitation with the nutrition and the dietary supplements, exercises, and lung transplantation. So these are the very important drugs to be used in most of our ILD populations. So the drugs here, the mycophenolate mofetil, cyclophosphamide, rituximab, azathioprine. So these are the important drugs to be used in the connective tissue disorders complicating ILDs. What about the differential diagnosis? See the DD of the interstitial lung disease. What are all the diseases so far I told you? They comes under your DDs like pneumoconiosis or drug-induced pulmonary injury, hypersensitivity pneumonitis, sarcoidosis, etc. What are the common complications left untreated? Most of the times, no. A average physician definitely will miss the ILD, and definitely these people will come to with these complications to the senior physician. So by the time the senior physician sees, so already had the infective episodes, pneumonias, tuberculosis, secondary infection, fungal infections, acute exacerbations of your ILDs, respiratory failure, pulmonary thromboembolism, pneumothorax. Okay. So the chronic complications, pulmonary hypertension, chronic respiratory failure, chronic congestive heart failure, iatrogenic complications, steroid related side effects, and then the scar leads to the carcinoma. And finally, very little can be done except to subject for your lung transplantation at this juncture. So the ILDs, if left untreated, will definitely have these acute or subacute complications and chronic complications. A third of the recovered patients is said to develop the fibrotic abnormalities post-COVID. So you all agree with me that a lot of our people post-COVID, they stayed in the ICUs for 3 days, 5 days, 10 days, 15 days, 20 days, etc. And finally, some of the people, they recovered very well. And these are the potential candidates to have the fibrosis. See here, 4%, they studied the autopsies. 159 autopsies of the COVID-19 patients with ARDS. 4% of the patients with a disease duration of less than 1 week. So less than 1 week, so they have the 4% with ILDs or fibrosis. 24% of the patients, duration between weeks 1 and 3. More than the 3 weeks, 61% of the patients had. So a lot of our people know they survived few people after the 4 weeks or the 6 weeks or 7 weeks of therapy. So definitely they are the potential candidates to have had fibrosis, pulmonary fibrosis. So you have to see the drugs that have to use the antifibrotic agents in such individuals who survived the COVID, but now having some dyspnea, some having dry cough, etc. So they must be having some pulmonary fibrosis in them. So diagnose them by subjecting for HRCT and then start using these antifibrotic agents. So the post-COVID pulmonary fibrosis, the risk factors. So these are the risk factors. So elderly, the more the chances. Illness severity and associated comorbidities. So COVID with diabetes, COVID with hypertension, COVID with CKD, etc. So definitely they are more prone for the fibrosis. Length of the ICU stay. So already told you the pictures also. Less than the 3 days or 1 to 3 weeks and more than the 6 weeks. So the more the length of the ICU stay, the more the chances of having fibrosis. Levels of the LDH. So the more the LDH, more the chances of having the fibrosis. Smoking will increase and chronic alcoholism. So predictors of the pulmonary fibrosis retrospective study. Here the Walder, more the CRPs, interleukin 6, longer terms of the hospitalization, pulsar steroid therapy and antiviral therapy, rituximab, etc. More dyspnea and higher respiratory rate. These are the people with more pulmonary fibrosis. So HRCT, irregular interface, parenchymal damage. More segments are involved here and larger lesion diameter also noted in this population. Too early in the course of the pandemic to be sure what the natural history of the post-COVID fibrosis is likely to be. So this is the images there, traction bronchiectasis, architectural distortion, loss of the lung volume, septal thickening, fibrosis. So the typical post-COVID lung fibrosis. Now the nintedanib, an antifibrotic agent to slow the progression of the pulmonary fibrosis. It is a tyrosine kinase inhibitor. So your nintedanib is a tyrosine kinase inhibitor. Maximum plasma concentration in 2 to 4 hours. Bioavailability nearly 5%. 20% better absorption with the food. Distribution in the plasma, blood to the plasma ratio 0.87. Elimination half-life 9.5 hours. It is a good metabolized, excreted through the fecus fecal and the biliary route. Dosing regimen already told you 150 milligrams BD. Common adverse reactions like diarrhea, nausea, vomiting, decreased appetite, most of the gastrointestinal side effects, some headache, decreased weight, and the drug-induced hypertension, like your steroid-induced hypertension. So nintedanib also will cause the hypertension. So it's approved in about 80 countries, including India, US, Australia, Singapore, Europe. It's a well studied drug. These are the different studies like Impulses 2, Impulses on, Tomorrow. So the different names given to these trials with the nintedanib, well tried drug. See here, after using this drug, there is about 52% relative reduction in the FVC decline. That is the Impulsive 1 trial. Impulsive 2 studies showed 45% relative reduction in the FVC decline. So you are preventing the progression of this lung destruction by using this tablets. So the Tomorrow study, 68% relative reduction in the FVC decline will be seen in these tablets. Okay, the same thing here. So it's another trial, inbuilt trial. So that shows 57% relative reduction in the FVC decline with the nintedanib. 3 out of every 10 patients had a stable or improved lung function at 52 weeks with the nintedanib. Don't use this like an antibiotic, 5 days or 6 days, etc. You have to use for so many years, definitely. So then you will have a good response with these drugs. See, 3 out of 10 patients. So 30% of the people have stable or improved lung function. See, the 4 out of every 10 patients had stable or improved lung function. So some differential points against nintedanib and the ferifenadine, that is also another antifibrotic agent. So both the drugs had a positive effect on FVC decline. Both are equally useful drugs. So finally, last slide. What are all the take-home points here? Interstitial lung diseases, although rare, are a serious health burden. Now no more a rare disease. Post-COVID, lot of cases of ILDs we are seeing here. Lung fibrosis is a key pathology in many types of the ILDs. So the basic pathology here is the lung fibrosis. Dyspnea, cough, unexplained weight loss, hypoxia, clubbing, oxygen desaturation, inspiratory crackles, characteristic spirometry, that is your reduced FVC, reduced lung volumes, reduced DLCO, and HRCT findings like your honeycombing, etc. They are the clinical manifestations of the fibrosing ILDs. Idiopathic pulmonary fibrosis is a commonly occurring ILD. It is also seen in other chronic ILDs with a progressive phenotype, especially systemic sclerosis. Post-COVID fibrosis is a common complication. Treatment for lung fibrosis involves antifibrotic drugs like nintedanib, anti-inflammatory like steroids, and supportive care with oxygen therapy or with secondary connective tissue disorders. You can use the disease-modifying rheumatology drugs, and non-pharmacological measures like pulmonary rehabilitation, oxygen supplementation, etc. Nintedanib, an anti-fibrotic drug, is a tyrosine kinase inhibitor that slows the progression of the disease by 40%, 50%, 68% also. 3 out of the 10 population, 4 out of the 10 population, they had a good response. Real world evidence highlights its benefits in lung fibrosis with marked reduction in the lung function declines. Finally, nintedanib is also a promising antifibrotic agent for treat the post-COVID fibrosis. So with this, I stop. A good doctor treats the disease, but yours should be a great doctor. Treats the patient who has the disease. So as I told you earlier, no, so don't treat the investigation, treat the patient in toto. So a great doctor treats the patient who has the disease. The art of medicine consists of amusing the patient while nature cures the disease. Always respect the nature. So by destroying the nature, we have seen what happened in the Vijayawada. Okay? Whatever the art of the medicine is loved, there is also a love of the humanity. So don't underestimate the medicine. So enjoy the medicine learning. So there is also a love for the humanity. So thank you very much, one and all.